Dr. Hamazoe, could you please describe how thermal therapy and surgical therapy are combined? The cases treated with thermal therapy were patients who had undergone surgery, patients whose tumors could not be removed by surgery, and patients with recurrent digestive organ tumors on whom thermotherapy was performed after surgery. No specific therapy was used before surgery. Most of the patients underwent surgery. We measured the temperature of a tumor by attaching a heat-conductive thermometer to the tumor during surgery. When a patient receives a thermal therapy without surgery, such as in the case of reoccurrence, a 21-gauge ultrasonic inductive elastomer needle is used to insert a thermometer. However, inserting a thermometer into a profound tumor in the abdomen every time thermal therapy is performed can cause great discomfort to patients. Also, complications due to punctures may occur. So when we see the relationship between the maximum RF output and maximum intratumor temperature, we realize that there is a strong correlation between the intratumor temperature and RF output. The temperature rises as the RF output increases. In addition, monitoring the antitumor effects according to each maximum RF output reveals that there are many effective cases in which the organ to be heated could properly be heated at more than 700 watts for the spleen and more than 1,000 watts for the gallbladder and pancreas. Thus, we can understand that the heating effect is beneficial when the RF output is high. According to these results, when the intratumor temperature cannot be measured, the maximum RF output is used as an index for the heating efficiency in the deep ventral cavity. There is no problem with the RF power being sufficiently increased, but it cannot be increased and the temperature does not rise if a patient feels heat or pain at the heated location. To deal with such situations, Voltaren suppositories are administered 30 minutes before thermal therapy. For patients with strong anxiety, Horizon or the like is administered through intramuscular injection. We have been looking into thermochemotherapy, which is the application of thermal therapy with anti-cancer chemotherapy. If we are seeking a combined effect with anti-cancer agents, it is better to combine the anti-cancer agents with thermal therapy. However, if the tumor temperature rises above 42 degrees Celsius, the volume of blood flow in the tumor will decrease somewhat, resulting in a decrease in the penetration rate of the anti-cancer agents into the tumor tissue. Therefore, we administer the anti-cancer agents soon after thermal therapy, when the blood flow rate within the tumor has increased. The types of cancer we have been treating include gastric cancer, metastatic hepatic cancer from colon cancer, gallbladder cancer, pancreatic cancer, and peritoneal metastasis. Here I can show you the results of treatment of a gallbladder pancreatic cancer that could not be removed by surgery. The direct tumor retraction effect was observed in 2 of 5 cases of gallbladder cancer and 3 of 7 cases of pancreatic cancer. A decrease in tumor marker was noted in 8 of 12 cases. In addition, improvement of performance or status was shown in 6 of 12 cases. Pain reduction effect was observed in 3 of 5 cases of pancreatic cancer with pain, with improvement in quality of life obtained. When comparing the survival period following thermal chemotherapy with that of non-surgery cases treated only by chemotherapy, a slightly better effect was obtained in thermal chemotherapy cases of both gallbladder and pancreatic cancers. This model patient, an example of corpus pancreatus, was a 69-year-old woman on whom trial surgery to remove the lesion was unsuccessful. After surgery, thermal chemotherapy was applied 34 times, including periods of hospitalization and outpatient treatment. A tumor that had been observed during a CAT scan performed before surgery had almost disappeared when viewed in a CAT scan performed 8 months later. Moreover, encasement of the splenic arch of the non-arterial root, observed in angiography before surgery, was alleviated after 14 months. This patient died 19 months following surgery of hepatic cancer, resulting from the original cancer. But the local control was effective 1 month before her death with no complaint of pain, and she was able to live normally. Thank you very much.